let's go back to work here. Here's another proposal. Accountable care organizations, moderate cost savings from clinical side, need to save costs elsewhere in the ICU. So it's shifting costs around a little bit. So you maximize benefit, take a little out of administration, put some more coordination in place. Anybody got experience with that?
A little bit. I still think we're on the front edge of this. I agree with the concept that we need to incent for outcomes rather than fee for service. And as long as we make more people involved, the patient, the provider, the payer involved in what the costs are and the expenses associated, then we should be making better informed decisions. But again, the key in that statement is coordination.
Okay.
It's also key, the long term is key here, because accountable care is really very much about the long-term view. It's not the short term, but also that's where prevention makes a lot of sense, because you're going to be accountable for those costs in 10 years. You're accountable for the patient, the total cost of care.
And then there was something called consumer-directed health plans. They claim they lead to reductions in the use of preventive care stuff from the
Consumer-driven plans are the norm right now, whether it's high deductibles or coinsurance or...
Is that what that means?
Yeah.
Higher deductibles?
It's the consumer is becoming more educated about the cost, and they're the ones having to make decisions because they're coming out of pocket more. So there's pros and cons to that. I don't disagree that it's potentially going to negatively influence appropriate medication use. Again, the challenge, though, is the employers are often faced with the question, can I even afford insurance? And so that's their solution, and it's not ideal.
But if what you're looking to do is roll people into this program and get them involved early, and there's lots of studies that show even a small copay diverts people away from HMOs. They don't come because they don't want to pay $1, $10. Is that counterproductive?
It could be. I saw yesterday a patient. I haven't seen him for about a year and a half. He now got an insurance with $10,000 deductible that he has to pay first before everything else.
$10,000.
$10,000. I even didn't know it existed. He found it. And he's 57 years old. He's got high cholesterol. He's got high blood pressure. He is refusing to do anything beyond a very basic laboratory test and not wanting to do any other preventive measure whatsoever.
Has anyone on this panel adopted a comprehensive disease management approach to type 2 diabetes and obesity together? And what are the challenges? What are the rewards here?
We have not together. I mean, we have education and programs around obesity, but again, we're not paying for drugs. So I think every plan out there has thrown everything under the sun at diabetes. It was an original HEDIS measure. It's been the qualities component has been around for over a decade. So we've tried everything. Again, newsletters, letters. Now it's more electronic. Case management, care management. I think everything's been thrown at it. I'm not sure if anything's super effective. Again, I think we've kind of alluded to where we need to go, and it's risk stratification and personalizing that and coordination of care. It can't be done from an affordable perspective on everybody. It has to be done on the right patient.
So from my management point of view, I do a comprehensive care. So I address, the different aspects of diabetes, and I talk with the patient, and I try to give them medication, try to simplify what I give them because I do have to do a lot, and I try to control what they have. And hopefully if I can show them result by 6 months, and then again by 1 year, it helps. In terms of my practice, my usage of cardiologists have gone much down. My usage of surgeries have gone much down. That's on an anecdotal basis that I can show it to you.
You talked about boots on the ground approach. Someone goes shopping with somebody to buy the right foods. It's expensive short term. Does it save money long term? Is this where we're going? Does it work?
Well, I don't have any data to say that it works or doesn't work, but I think it's a novel approach to, empower a patient to, one, read nutrition labels, understand food choices, et cetera. And that's an important cog in the whole management of diabetes. So you need lots of cogs, and it's a complex problem, but, that's just one small thing that so potentially could work.
Where's the big upside? Where's the room for improvement? We got drugs. Those are in the pipeline. They're coming out. We've got good research on the kind of problems we need to deal with. On the clinical side or the managed care side, Maria, where's the next big move? Where's the room that we need to improve?
Well, I think where we need to improve is, frankly, on the innovation side. We've tried a lot of things. We have many more different mechanisms of action, more drugs, more options, more choice. I think where we need to move from here is how do we collectively work together? And that means the patient, that means the provider, that means the health plan, that means even behavioral health. How do we collectively work together, thinking about the patient to get them to goal and to get them there and, with hopefully the most efficient, the most cost-effective alternative, hopefully the safest as well. But that's going to require an individualized approach. I mean, that's the secret and the magic to this is how do we individualize that? How do we motivate patients? Without that patient motivation, we're not going to go beyond that.
How do you take this individualized approach and institutionalize it into something that you can put into some sort of algorithm or a case management plan that people can then can institute across the board, across the
No,
whole
it can be done, and it's being done now through triggers and risk stratification, and then coordination of care through integrated care management and pharmacist-centric MTM. So I totally agree. I think that's the approach, but it has to be around breaking down the silos because that's the challenge right now. Even you've got these different stakeholders, whether it's the provider, the member, or the patient and the payer, but even within managed care, you've got medical who doesn't talk to pharmacy very well. So it's got to be about reducing silos, and it's got to be about risk stratification and integrated care management and patient-centric MTM.
Is this going to work?
Well, I think on the clinical side, I think, we mentioned where we talked about adherence earlier. I mean, those numbers are dismal. If we could even improve adherence 10, 20%, I think you're going to see improvement in these numbers.
So yeah, I think that I agree that we really have a lot of the tools, especially for diabetes, that we need to. We may want to have some better tools on obesity. How to deliver it, the time to deliver it, the expense to deliver it is really where the issue is going to be as we get larger population and more that we need to address. So I'll go back and to say that we do need to focus on that prevention. And maybe we'll have to go after China. I don't know if you recognize it. They have in China now 136 million people with diabetes. This is more than the whole country of Mexico. We have now in China over 500 million people with pre-diabetes. This is so scary. They're just now realizing it. And they started to institute programs. And we may have to look at those programs because for them, they just took 15,000 educators out there to work on 200,000 people and to see how they make a change. We are still not there to be able to do it. They are, but we'll have to learn from them.